Three, two, one. Good morning from Miami. This is Dr. John Bennett of Neurosurgical TV. My camera's not working, but let me first introduce the panel members, and then I'll turn it over to Yuha, Yuha Hernes-Niemi, who's going to introduce Ben. Welcome, Hira.
Hi, hello John, hello everyone. This is Hira from Karachi, Pakistan. I'm the president of the ACNS Student Society, and it's a pleasure to have you all here with us.
Yeah, welcome, Hira. And Hira's arranging for a women's neurosurgical conference shortly.
Yes, we are having a women's neurosurgical conference this Saturday, and we look forward to that.
Very good, Hira. Okay, good day, Duong. Could you please introduce yourself?
Oh, me?
Yes.
Oh, yeah. Hello, guys. I'm Peter Wang, and I'm from China, Taiwan, but now I'm the medical student in 4th year studying in Italy, Milan.
Yeah, welcome, Peter. And Duong, could you please introduce yourself?
Yeah, hi everybody. My name is Kian. I'm from Hanoi. I'm a neurosurgeon in St. Paul Hospital. Nice to meet all of you.
Welcome, Duong. Juma, how are you doing today?
I'm fine.
Could you please introduce yourself?
Yes, my name is Dr. Yuma. I am from Tanzania. I'm doing my fellowship in India. Nice to meet you all.
Welcome back, Juma. And Simon. Simon, due to etiquette in Japan, he does not like to speak on the subway. And I'll introduce Yuha Hernes-Niemi, who's going to introduce Ben. Hello, Yuha.
Hello, hello.
Could you please introduce Ben, please?
Hi, I'm Ben Xu from Shanghai.
Okay,
Hello.
you want to do an introduction from Ben, please, Yuha?
I begin now?
Yes, please. Please introduce Ben.
Okay. I was recently in St. Louis, and for some reasons they counted how many times I have been in USA in last 5 years. It was 29 times in last 5 years. And I have given certainly more than 100 presentations. And one of the slides is go to East to learn. Go to Japan, go to Korea, go to China, because there is big competition, high number of cases, and excellent neurosurgery. This has been my message. I don't know how many guys from West came to there, but I want to introduce you, like I have earlier said Ping Su, but now I know it is called Zubin or something like that. He's my very good friend. I'm not speaking for a friend, high words, but he's one of the greatest talents in neurosurgery. At the moment, he's 45 years old, was trained in one of the largest neurosurgical centers in the world, in Shanghai, Huashan Hospital, became specialist 2005, and has spent time in San Francisco, USF, and also in Paris by my friend Jacques Moret, and in Helsinki several times. So slowly we became friends in spite of our large age difference. I think we have known each other 15 years. So now he's working in Fudan Hospital, Fudan University. Yeah. And why he's something special? He's 45 years old, and he's already world champion in bypass surgery. He has done 4,700 bypasses, mainly in moya diseases, 90%, but the number of bypasses is something that no one else can achieve in lifetime, and he has at least 20 years left in neurosurgery. So last year he made 800 bypasses. Yes, he's going around Shanghai in different hospitals, and his record in bypasses is 9 operations in 1 day, and occlusion time limit the record. So he's something very special, and what is special in him that he's humble, simple man, like Dr. Drake always said, I'm just an ordinary man in spite of his great talents and huge experience. He has remained a very humble guy, and I thank him for one special thing because he brought me to China. So listen to Xu Bin, one of the greatest neurosurgeons in the world, already at this young age, and he has so many years left. I wanted that the whole world knows him and comes to visit him to see his special surgery. So, Xu Bin, please give your lecture.
Okay, Ben, welcome.
great.
Okay, it's all yours, Ben.
Okay, great. Thank you. Thank you, Professor Hanisnimi. You are my hero. So, dear colleagues, so today my topic is the surgical treatment of Moyamoya disease. So, John, can I begin to the presentation?
Yes, please.
Okay, okay. So you can see the PPT very well?
Yes.
Yes.
Okay, okay. So now we use Suzuki stage to of DSA to measure the severity of the Moyamoya disease. So this is stage 1. We can see the stenosis of the distal part of ICA and the proximal part of MCA and ACA. This is a stage 2. We can see the Moyamoya vessels developed. And this is a stage 3. We can see the Moyamoya vessels spreaded a lot. And this is a stage 5, stage 4. Actually, because the severe stenosis of the ICA distal part, it looks the Moyamoya vessel decreased. And this is stage 5. We can see the some spontaneous stoma comes from the ECA. This is a stage 6. The ICA was totally occluded. Like this patient, we only can see the ophthalmic artery from the ICA. The intracranial part of the ICA was totally occluded. The incidence of Moyamoya disease in Chinese is similar in male and female, while it's female predominant in Japanese. So this is a different pattern. So I always use a combined approach if it's feasible. The indirect part was encephalomyosynangiosis, and the direct part is STA-MCA bypass. Sometimes, if the parietal branch of the STA was substituted by the postauricular artery, so I choose the postauricular artery anastomosing to MCA. And if there's some occipital lobe ischemia, sometimes I choose occipital artery to PCA. So the purpose of the surgery is to allow the maximum use of the 3 arteries, the STA, postauricular artery, and the occipital artery, which are supplying the scalp, and the middle meningeal artery supplying the dural, and the deep temporal artery supplying the temporal muscle. So by now, I've finished more than 4,700 cases. So the ischemic type of the Moyamoya is 2,754 cases. hemorrhagic ones is 2009 cases. So the STA-MCA bypass combined EDMS. Every patient was individualized, designed. The skin incision and the bone flap and the dural and the targeted bypass. So the scalp flap was individualized, designed according to the anatomy of STA, occipital artery, and the post-auricular artery, and the middle meningeal artery, and the ischemic area, just like this. So just like this one, we can the left upper one, we can see this the parietal artery, the parietal branch of STA has some spontaneous stoma with the cortex artery. So we use frontal branch to create the bypass and the EDMS. And the second one, we can find some spontaneous stoma from middle meningeal artery. The frontal branch has already feeding the frontal lobe, so we just use the parietal and the temporal cortex. So this is all different scalp design according to the different anatomy. Sometimes the invalid bilateral EDAS, the patient have no spontaneous stoma from the STA, which is attached to the cortex. So by this kind of patient, we can still use surgical treatment for him. Like this patient, I designed a bifrontal lobe EDMS combined the bilateral frontal branch STA to frontal cortex artery anastomosing. Sometimes the direct bypass was infeasible. Just like this patient, this kind of patient, the cortex artery was very, very fragile and very thin, and it's impossible to do the direct bypass. The right patient, we can see some cortex artery, the branch of MCA was occluded totally. And beside, there's some very small artery. So this is dangerous if we do the direct bypass. So the direct bypass was infeasible, more likely in female patient. So dissecting STA, I always use inner side of the scalp. So the mean time in female is 7 minutes. The male patients would take a little bit more time. Mean time is 9 minutes. Because the female patients, the STA has less big branches, and the STA diameter is around 1.02 millimeter. And the male patients, it has thicker. So this is a different STA diameter. We can see the left side is a male patient, and the parietal branch of STA was very thick. And on the right side, it's a female patient. Actually, this patient, the STA only has frontal branch, and the parietal branch was substituted by the post-auricular artery. So this is my way to dissect STA from inner side of the scalp. So use this method, the STA can be dissected very quickly. The mean thickness of the female scalp is around 6.5 millimeter, and the mean thickness of the male scalp is thicker. It's around 7.8 millimeter. So the incidence of delayed scalp healing or infection is higher in female patient. Now I always close the incision of the superficial temporal fissure like this way. So the scalp was two-layer suturing by the inner side. So after this treatment, the delayed scalp healing or infection of scalp never happened after this treatment. So the secret of the Moya Moya surgery is keep the integrity of STA, deep temporal artery, and the middle meningeal artery. So this kind of patient is very sensitive to the blood loss. So the creotomy should be controlled the bleeding loss very strictly. In my team, the bleeding volume loss was less than 20 milliliter. In stage 5 or 6 patient, we can see the spontaneous stomas from the middle meningeal artery. So this kind of patient, actually, we can protect the spontaneous stoma very well. Use divided bone flap like this. So I think the best protection of middle meningeal artery is keeping integrity of the middle meningeal artery, middle meningeal vein, and the covered bone complex. Like this way. And in some special patients, there's some other spontaneous stoma from different area. So we can use, like left side, I choose a single bone flap, combine multiple hole. And the right side is a double frontal bone flap. So the dural flap was also designed, individualized according to the main trunk and the branches of the middle meningeal artery. On the right, the inferior part, inferior figure, we can see the spontaneous stoma from middle meningeal artery to the cortex. Sometimes the bleeding of the middle meningeal vein is very annoying, like this. Actually, this kind of bleeding can't be coagulated by the bipolar. So I use this kind of treatment. Use a gel form. So it's just like make a spring roll. So I called it a Chinese spring roll. So I think this is the best way to keep the integrity of middle meningeal artery, but stop the bleeding of the middle meningeal vein. So the stomas normally located in ischemic area. But we should know that the infarct area was not fit located. So I always use most simplified anastomosing like this. I never use a silicone paddle, and I use two curved temporal clip like this, and never sacrifice any small branch of the recipient artery. This is a 10-0 breathing suture. Yeah. 这个屏幕上没有吗？录像有吗？有。So the first stitch is at the toe of the stoma, then the heel. So when we make the knot, we should pay attention to the direction of the suture tear. So this is a two knot. The square knot is enough. So like this patient, only within 8 minutes, I finished the stoma. Okay. Sometimes I use loop technique. 没有. I'm sorry, the video in my computer is played properly, but in the screen, I can't see the video playing.
No, it's not saying.
Actually, after the bypass, the stoma can be enlarged. So this is my follow-up case. So it's 3 times on the cover of the Chinese Journal of Cerebral Vascular Disease. So sometimes, actually, I can use one branch to create the double barrel bypass with the parietal branch of STA. So this, so use this kind of method, I can preserve the frontal STA branch for more blood supplying of the scalp. So the targeted bypass, this is a single bypass located on the parietal lobe. This is the double bypass located on the ischemic area of the temporal lobe. This is a triple bypass located in the temporal lobe and the frontal lobe. So the mean temporal occlusion time of MCA branch is 30.8 minutes. So actually the blood volume from the bypass are according to the Poiseuille Law. So this is a Poiseuille Law. So we can see that delta P is the only motive power for driving the blood flow. So to create a successful bypass, we must make sure to keep the delta P positive. So the stoma near the high pressure location is dangerous for delayed occlusion of the bypass. So we should select the right position of the recipient artery. So before the bypass, we should analyze the MCA blood flow. One kind of the blood flow according to the physiological direction. Like this patient, we can see the proximal part to the distal part of the MCA. So in this kind of patient, the pressure of the proximal part of the MCA is bigger than the pressure of distal part. But sometimes we can find some MCA blood flow. It is reversed from the physiological direction. Like this patient, we can see the proximal part come to the distal part. The distal part comes to the proximal part of the MCA network. So in this kind of patient, the pressure of the proximal MCA was less than pressure of the distal part of the MCA. So use ICG flow 800, we can see the bidirectional fast blood flow means a big difference, different of delta P. We can see the blood flow comes from the donor artery to the recipient artery. Then the blood flow comes to bidirection. So on the left hand, we can see this is a single bypass. On the right side is a double bypass. We can see the blood flow comes from like this. So this means the bypass is sustainable. But sometimes, if the delta P is very positive, like this patient, actually we can see the stoma very close to the balance point of the pressure. We can see the balance point around here. So the blue point is the balance point. So after 5 days, almost occluded the bypass after 1 week. So this is I borrowed the video from doctor from Wuhan. So the donor artery and the recipient artery is different. The donor artery is STA, sometimes post-auricular artery, and the under the occipital artery. So the wall is normally
Okay, I guess we had a little glitch there. I think hopefully Dr. Ben will be coming back. Can everybody hear me okay?
Yeah.
Yes, we hear you okay.
Okay.
Yeah, sure. Okay.
Do you have any comments so far, Yuha, until Dr. Ben comes back? Oh, okay. Well, let me try to reach Dr. Ben, and Slaven, you can handle this while I'm gone, okay?
Yes, no problem.
Okay. Could you I'm just oh, he's back. Okay, he's back. Okay, I'm sorry about
Okay,
that.
sorry.
Okay, that's okay.
Okay.
Please continue.
So the recipient artery is thin wall, and the resistant index in situ was 0.5 to 0.6. Sometimes in the early stages of moya case, we can find the good MCM network. So after bypass, the blood flow reflects to M2 and redistribute the blood flow quickly along the network of the MCA. But in high stages of moya case, the MCA network was poor, and this kind of patients can got the congestion of blood flow in limited cortex, and which is dangerous for bleeding or infarction or edema. So this is a good MCA network. So we can see the network of MCA, although it's delayed, but it looks good. So this kind of network can bear more blood flow from donor artery. The lower figures, we can see the poor MCA network. Actually, in this kind of patient, we couldn't figure out the MCA network in DSA. So this poor MCA network can be a small amount of blood flow from donor artery. So it's dangerous for bleeding after direct stomas. So this is a good MCA network. We can see the blood flow comes from the donor artery, reflects to MCA, then redistribute along the MCA network. And I prefer to choose the bifurcation of the recipient artery, which can distribute the blood flow more quickly. Like this patient, I choose the stoma location near the bifurcation of the recipient artery. So this is the EDMS. After the direct STA-MCA bypass, and then the muscle, the temporal muscle was covered the cortex and suturing to the bone window. So in Huashan Hospital, we have some intraoperative MRI, and we can use the NOVA system to measure the blood volume from the donor artery. So normally the intraoperative MRI measuring the STA is normal is from 20 to 30 millimeter per minute. But after several days, like this patient, 7 days after operation, the blood volume from the donor artery increased to 77 millimeter per minute. In the double bypass cases, it's easy to exceed 100 millimeter per minute. So this is a STA flow by NOVA. The left column is pre-operative and the right column is post-operative. The male patients carries the STA carries more blood flow than the female patients. The long-term follow-up, we can see the different right side, the MCA network was pretty good. So this patient, the right STA carries 140 millimeter per minute blood flow. But on the left side, the left STA only carries 91 millimeter per minute because of the poor MCA network. So this is a good right MCA network. The STA bypass diameter increased to 3.3 millimeter under the feeding big MCA territory. This is a follow-up of 3-dimension DSA of right ECA. This is the same patient with a poor left MCA network. The STA bypass diameter is 0.9 millimeter, much less than the contralateral side. So it's only feeding limited superficial territory. So we can see the stoma around here. So the MCA network is also play a crucial role in determining the blood flow volume in bypass. So the Moya-Moya STA-MCA bypass in Moya-Moya is blood flow augment bypass. So the more blood flow, the better is not correct for Moya-Moya disease. Males STA carries more blood flow than females, and the diameter ratio of the donor artery comparing to the recipient artery, if it's bigger than 2.5 times, we should consider quit bypass because it's dangerous for bleeding. And control the blood volume, use Poiseuille Law. We can choose a different location of the stoma and the different length of the donor artery to control the blood volume. And the condition of MCA network is a key role to determine the blood flow volume in bypass. So the thin STA, if the STA was thin and the MCA network was very good, we can choose the multiple barrel bypass. So in Moya-Moya, not only the direct bypass, the EDMS is also very important. Like this patient, we can see the long-term follow-up. So besides the direct stoma, the spontaneous from middle meningeal artery and the deep temporal artery developed very well. And almost the whole hemisphere was supplied by ECA, and the ICA was already occluded. So even it's supplying the contralateral side hemisphere. Like this patient, we can see the STA diameter is around 3 millimeter. And we can see it's supplying not only the even supplying the contralateral side. So the determinants of a blood flow after bypass, at first we should consider the carrying capacity of STA. So sometimes we quit direct bypass. One condition is no recipient artery. Sometimes the artery was too large and the recipient artery is too small. And the bypass, we can create single bypass. Sometimes branch to barrel bypass. And the location of the stoma is very important. So that is the only driving power of the blood flow. we should measure it very carefully before the surgery. Analyze the blood direction of the MCA network. And then we should consider the carrying capacity of the recipient artery. So the integrity of MCA network also plays a very crucial role. So this is my personal experience in Poiseuille disease. Last year, I performed 800 cases. So by now, my personal record is 5 minutes, 40 seconds to finish a stoma, and 9 cases in 1 day, 31 cases in 1 week, and by now it's more than 4,007 bypass cases, totally in 109 hospitals in 26 provinces of China. So 9 cases in 1 day.
Okay, well, temporary glitch looks like he dropped off again. While we're waiting, I'd like to introduce a couple of new panel members while we're waiting for Dr. Bin to come back on. Hello, Mohammed. Oh, I'm sorry. We'll take care of the introductions later.
Okay, John.
Okay, continue.
Okay,
Go ahead.
Okay. So a lot of very famous neurosurgeons from all over the world, including Johan Nemi, visit our department. This is Luca Wrigley. And I also have live case in India. So thank you. This is my presentation. The 2020, the International Conference of Poiseuille Disease was hosted in our department. Thank you.
Okay, very good. Thank you, Dr. Bin. And we hope we have a lot more presentations by Chinese neurosurgeons like yourself.
Okay.
I guess, and you're welcome to come back anytime. And we hope to televise a conference that's led by Juha Hernes-Niemi at the end of in May. I guess I'll let Juha kind of lead the discussion. We'll start off with Juha. Juha, do you have any comments for Dr. Bin? You got to unmute yourself. Unmute. You're muted. Juha, you're muted. Your camera is muted. We need to take it off. There you go. IPE is there to solve the problem. There you go. Okay, go ahead, Juha. Go ahead, Juha.
Can you hear me now?
Yes, we can.
Can you hear me now? Okay.
Yes, we can.
You hear this lecture, people around the world. This is unbelievable experience for a man, 45 years old. So please take a flight, China, Shanghai, and take a look. I know in many places you don't believe the experience. And I had visitors in Helsinki, even they were 1 week with me, they didn't believe. So very important message, very important lecture, one of the largest experience. So this only that country, China, with big population and centralization of the cases are in extremely talented hands and in extremely efficient teams. You can do that kind of surgeries and have that kind of results. So my questions, this was telling about this very special series. But my question is there any clue why this moya moya disease is born? What is the origin of the moya moya cases, and then why this disease is more common in Chinese and Japanese? And second question is, what happens to these patients after the bypass surgeries?
Did you get that, Dr. Ben?
Yeah.
Okay, go ahead.
John?
Yes, can you answer that?
Yeah.
Comment by you.
Actually, you asked what platform I used. Actually, I'm using the Neurosurgical News. It's a Chinese platform, and actually they want to cooperate with you, the Neurosurgical TV. Actually, we can transform a lot of Neurosurgical TV in Chinese version, and then I think it would be a very great cooperation.
Oh, okay. Okay,
Yeah.
Dr. Ben, Yuha had a question. Did you hear his question? Okay, let me go back to Yuha. I don't think you heard the question. Did you?
Yeah, I didn't hear the.
Okay,
question.
let me, Yuha, could you please repeat the question for Dr. Ben, please?
Is there any clue why moya moya disease is born? What is the reason for moya moya disease? And second question is, what happens to these patients which have bypasses? Do they have normal life expectancy, or what happens to them?
Okay, by now we actually have long-term follow-ups for the patients from 2003. So the longest follow-up is 15 years. So normally we still have some rehemorrhage case, but the rehemorrhage rate is decreased from the normal the natural history around 7 to 8% decreased to around 2% annually. So now, by now, the result is pretty good. But the lifespan, we can think. I think we should follow up all life of the patients.
Very good. Okay, I'd like to take this opportunity to introduce Mohammed. Mohammed's a resident that's in China now, a neurosurgical resident. Could you please introduce yourself, Mohammed? Yeah, unmute yourself there. There you go.
Yeah. Hi, everyone. Actually,
we can't hear you, Mohammed. I don't know why. There's no audio there. Okay.
Can you hear me?
We'll try to.
I can hear fine.
Can you hear him?
I can hear Mohammed fine. Yeah.
Go ahead once again, Mohammed.
I could.
Hi, everyone. Actually, it was so good webinar. I need to thank all of you and especially.
You can hear that, Slaven?
It's fine here.
No, Mohammed, I'm sorry, I can't hear you, unfortunately.
Sorry, Mohammed. Okay. Yeah, Dr. Bennett can't hear you for some reason.
Yeah, we'll work on that. We'll work on that. Now, Duong or Yuma, do you have any comments or questions for Dr. Ben? Hello, Duong or Yuma, do you have any questions or comments for Dr. Ben?
Nope, for so far.
You have to. Okay, go ahead, Duong. Go ahead.
I have no comment. Thank you.
Okay, thank you. Yuma, do you have any questions or comments? Can you hear me okay, Yuma?
Yeah, no, I don't have any questions.
There you go. There you go, Yuma. Okay.
I don't have any questions.
Go ahead, Yuma.
I can hear you, but
okay, sorry, we're having a couple of technical difficulties. Well, I'd like to introduce Slaven, the ACE neurosurgical medical student from Croatia. Maybe you have a question or comment for Dr. Ben.
Well, thank you very much for the opportunity to participate here. I am a medical student from Croatia, as Dr. Bennett said, and I am also working here with Neurosurgical TV. I have one question, which I hope won't be too complicated. I mean, with my talk, it's just about what is your prediction for the future of vascular neurosurgery? I mean, if we observe in sometime in the back, most of the cases were which vascular neurosurgeons were doing were aneurysms before coiling techniques and endovascular techniques. And now, what do you think in the future that vascular neurosurgery will progress towards? So that would be my question. Thank you and thank you again for, as Professor Hernesniemi said, a milestone presentation in our program.
Thank you, Slaven. Okay, Dr. Ben, did you hear Slaven's comment or question, Dr. Ben?
Yeah, just like Juha Hernesniemi said, that the bypass is the future of neurosurgery. So I think the vascular neurosurgeon, actually I'm both doing the open surgery and the endovascular treatment. So if you do both, you can understand the vascular disease better, I think. And actually, not only treated you can choose the best way to treat the different disease, like the ophthalmic artery aneurysm. Normally, the endovascular treatment is more simple than the open surgery, and the post-circulation artery aneurysm. Actually, the endovascular treatment is much easier than the open surgery. So if you're doing both, you can handling the both techniques. You can choose the best way to treat the different disease. And bypass is also very important in the complex aneurysm treatments. And actually, I also have around 200 cases of aneurysm bypass. So maybe I can present it later. Yeah.
That would be wonderful. And may I just ask Professor Hernesniemi to also, what is vascular neurosurgery? I'm sorry to interrupt.
Okay, let me just take this opportunity. Mohammed, I always have audio problems. I guess they can hear you. Can you once again introduce yourself to Dr. Ben? You're in China, correct, Mohammed?
Yep. Hi, everyone. Thank you for this fruitful webinar. Actually, I'm a medical student here in China, and I was honored to meet Professor Shubin last year when he came to our hospital to do like 10 Moya operation. So I was so inspired by him. It's not my first time to know him actually. So I need to thank him so much for this fruitful webinar.
Yeah, great to see you, Mohammed. Yeah, you are in the picture of the 10 cases.
Yeah.
Yeah.
Yeah, just so that.
Nice to meet you again. Yeah.
Thank you.
Okay, very good. I'm glad you get to meet Mohammed. Uma, could you please introduce yourself to Dr. Ben and Juha? You're there, Uma? Uma's a medical student from Morocco.
Hello, Dr. Ben.
Go ahead, Uma.
Hello, everyone. Thank you for the presentation. I actually have a question.
Okay.
I don't know if you can hear her. Can you talk, Uma? I don't know if I can hear you.
Okay, can you hear me?
Okay, well,
we can hear her. We can. Yeah.
Wow.
Well,
okay.
You can continue, and I can narrate. It's okay.
First,
yeah, why don't you take over, Slaven? I can't hear a lot of people. Go ahead, Slaven. Take over.
Okay.
Take over.
Okay, please go ahead, Umema.
First, I want to thank you for that presentation, and to thank everyone for sharing their information and their knowledge. I actually have a question for Dr. Ben. I have seen for the first time the Moya movies. with my professor operating on aneurysm, and I want to ask if the fragility of the arteries in the Moya-Moya disease have anything to do with the aneurysms. I mean, if someone is having the Moya-Moya disease, is there a predisposition for them having an aneurysm?
Actually, sometimes Moya-Moya case also have some aneurysm. Actually, I treat around 10 cases with ACAM or PCAM aneurysm. But normally the aneurysm is a peripheral aneurysm. Actually, its location is very deep and just beside the ventricle. So this kind of peripheral aneurysm shouldn't be treated directly. Actually, after the STA-MCA bypass combined EDMAs, after 6 months later, we recheck the DSA. Normally, this kind of peripheral aneurysm was disappeared. So we already reported around this kind of patient, this kind of case for 10 cases. We already have some article for that.
Okay,
You can check
so
it. Yeah.
Okay, thank you so much. Thank you.
Okay, and just to ask if Hira or Peter have any questions or comments, please go ahead and ask, or any remarks about this presentation. Thank you.
Thank you, Savan. I do not have any question, but I would like to thank Dr. Ben to come up and give such a good presentation to us. It's an honor for us to have you with the ACNS Super Sundays, and I look forward to have you in the next presentations as well. Thank you.
Thank you, Hira.
Thank you.
Yes, please go ahead.
Yes, yes. Thank you, Dr. Bin, also as well for the presentation. And so far, I don't have any question. But thank you so much for today for the presentation and the lecture.
Mm-hmm. Do you have any remarks about the presentation so far? Remarks? Any remarks? No?
No, don't worry.
Okay. Okay, thank you.
Yeah, because oh yeah, sorry, because I think it's just my local Wi-Fi issue. Don't worry. Yeah.
Okay, so if any other panel members have any comments or questions, you're free to ask, please, before we finish this presentation.
Yeah, actually, I have one question.
Go ahead, Mohammed, please.
Yeah, I need to ask Professor Shubin if there is any technique that we can measure the pressure in the artery before we do the operation.
I would like to comment. I think you were asking about the future of cerebrovascular or vascular aneurysm. So,
thank you.
So I think it has a great future because 5/6 of the world has still no access to endovascular surgery, and what we are speaking here is first world talk. So the costs of endovascular surgery are immense and huge until now, until the prices of those stuff that is pushed inside the muscles is getting low. It remains at least the fate of the poor patients to have open microsurgery or no treatment because they have no money to pay the treatment. So in respect of that, we should think differently, not to discuss on the highest level which treatment is the best one, but also globally. Of course, we can discuss if it's necessary to do somewhere aneurysm or Moya-Moya disease surgery. If with a few money you can prevent malaria, or buy clean water, or buy food for healthy children and save lives. These are difficult questions, but I think very important is the economical thing that most of the people cannot afford, simply cannot afford endovascular treatment, and even many cannot afford open microsurgery in case of aneurysms. But this is the background, and very important background when discussing which treatment policy is the best. The future of cerebrovascular surgery is great. There will be new ways of treatment, and I think those who are pessimistic about that, the future, are right, because in 30 years there will be no endo or extravascular surgery because the aneurysms are treated by biological means like ulcus ventriculi, ulcus duodeni is no more treated by surgery but by antibiotics. No young medical doctor knows anymore what is Bilroot operation for ulcus ventriculi duodeni, which I have assisted hundreds when I was young medical doctor. It was resection or bypassing the ulcus duodeni. Nowadays it is simple antibiotic treatment. We are doing research. We will find the cause of aneurysms, why the aneurysms are formed, and we will have direct treatment for them. And then all this technology will disappear. This is my thinking. Very young guys who have 30 years ahead, you can do cerebrovascular surgery a lot, and to be better, you have to do and to learn to do bypass surgery and go to the places where this is really done and in high amounts. Once repeated, go to East, learn.
Thank you so much, Professor. Thank you so much for your insights, because I was really asking. I mean, you hit every point which I wanted to actually ask, and that is the economical future and also the future for younger generations to come, because it is enormous how the development went for as I studied it and tried to grasp it. So thank you very much for, I mean, this is a very impressive answer for myself. I would like to give space now to Mohammed just to ask his question, and then we will proceed to the next presentation. Please, Mohammed.
Okay, thank you. I need to ask Professor Shubin if there is